Juvenile Idiopathic Arthritis. 1. Introduction. Juvenile Idiopathic Arthritis, JIA, is the most prevalent chronic rheumatic disorder of childhood. It is a heterogeneous group of autoimmune diseases characterized by chronic inflammation of the synovial joints. Unlike transient arthritis following infection or trauma, JIA persists beyond 6 weeks, beginning before the age of 16 years. The disease not only causes musculoskeletal disability, but can also affect extra-articular organs such as the eyes and skin. Early recognition and treatment are crucial because untreated JIA may result in long-term complications including joint deformity, growth retardation, and psychosocial distress. 2. Definition. The International League of Associations for Rheumatology, ILR, defines juvenile idiopathic arthritis JIA as arthritis of unknown origin, beginning before the age of 16 years, persisting for at least 6 weeks, and not explained by other known conditions. 3. Etymology. Juvenile refers to onset during childhood, 16 years. Idiopathic denotes that the cause is unknown or not attributable to a specific agent. Arthritis, derived from Greek words arthro, joint, and itis, inflammation, meaning inflammation of the joints. And now here 4, epidemiology, global prevalence, 1 to 2 per 1,000 children. Incidence, 2 to 20 per 100,000 children annually, varying by region. More common in girls than boys, ratio 0.2:1, except in enthesitis-related JIA where boys predominate. Peak age of onset, 1 to 3 years, oligoarticular type, and 9 to 14 years, polyarticular and ERA types, associated with significant healthcare burden due to its chronic nature. Shadafar 5, types, ILR classification. 1. Oligoarticular JIA involves D4 joints in the first 6 months, most common type, risk of chronic uveitis. 2. Polyarticular JIA, RF negative, pull 5 joints, usually symmetrical, similar to adult rheumatoid arthritis. 3. Polyarticular JIA RF positive resembles adult seropositive RA, often severe, affecting adolescent girls. 4. Systemic JIA Still's disease features arthritis with fever, evanescent rash, hepatosplenomegaly, and serositis. 5. Enthesitis-related arthritis ERA, arthritis with enthesitis, strongly associated with HLA-B27, more common in boys. Psoriatic arthritis, arthritis with psoriasis or typical features, dactylitis, nail pitting, family history of psoriasis. 7. Undifferentiated JIA, arthritis that does not fit into the above categories. Number 6, causes. The cause is multifactorial and idiopathic. Contributing mechanisms include genetic factors, HLA associations, e.g. HLA-B27, HLA-DRB1 alleles, immune dysregulation, abnormal T-cell activation, autoantibody production, ANRF, environmental triggers. Viral or bacterial infections may trigger immune responses in genetically predisposed children. All 7, risk factors. Female sex, especially in oligoarticular and polyarticular subtypes. Family history of autoimmune rheumatic diseases. HLA-B27 positivity predisposes to ERA. History of early childhood infections. Environmental exposures, secondhand smoke, low vitamin D. 8. Complications. If untreated or poorly controlled, JIA may lead to joint damage, contractures, deformities, ankylosis. Growth disturbances, stunted growth, leg length discrepancy, micrognathia. Uveitis, silent but sight-threatening eye inflammation, osteoporosis, due to inflammation and corticosteroid therapy. Systemic complications, pericarditis, macrophage activation syndrome, MAS, and systemic JIA. Psychological burden, depression, anxiety, social withdrawal. 9. Pathophysiology. In JIA, the immune system mistakenly attacks synovial tissue. Activated T cells, B cells, and macrophages release inflammatory cytokines, TNF-I, IL-1, IL-6. This causes synovial hyperplasia, vascular proliferation, and infiltration of inflammatory cells. A pannus, granulation tissue, forms, invading cartilage and bone, leading to erosion and deformity. Chronic inflammation also disturbs growth plate activity, causing abnormal bone growth. 10. Signs and symptoms. Persistent joint swelling, pain, or stiffness, Esper morning stiffness. Limited range of motion, limping or refusal to use affected limb in younger children, fatigue, irritability, loss of appetite, fever, rash, hepatosplenomegaly, systemic JIA, eye problems, redness, blurred vision, photophobia, uveitis. 11. Medical diagnosis. Diagnosis is clinical and requires exclusion of other causes. Tools include history and physical examination, laboratory tests, ESR, CRP, indicators of inflammation, ANA, positive in many oligoarticular cases, predictor of uveitis. RF and anti-CCP, markers for polyarticular RA like JIA. HLA-B27 linked to ERA. Imaging, X-ray, late changes, MRI and ultrasound, early inflammation. Ophthalmology screening to detect silent anterior uveitis. Number 12. Nursing diagnosis. Chronic pain related to inflammation. Impaired physical mobility related to joint stiffness and pain. Activity intolerance related to fatigue and disease progression. Disturbed body image related to physical deformities. Risk for delayed growth and development. Ineffective coping related to chronic illness. Letter 13. Medical management goals. Control inflammation, relieve pain, prevent disability, and promote growth. NSAIDs, ibuprofen, naproxen, first line. Corticosteroids, for acute flare-ups, systemic JIA, or intra-articular injections. DMARDs, methotrexate, gold standard, leflunomide, sulfasalazine. Biologics, anti-TNF, etanercept, adalimumab, infliximab. IL-1 inhibitors, anakinra, canakinumab. IL-6 inhibitors, tocilizumab. Regular monitoring for toxicity, CBC, liver, renal function. 40. Nursing management. Assess and manage pain using scales appropriate for age. Encourage physiotherapy and regular exercises to maintain mobility. Educate child and parents on medication adherence and side effects. Support adequate nutrition and monitor growth parameters. Assist with joint protection, splints, positioning. Provide emotional support and counseling for family. Collaborate with a multidisciplinary team. Treatment options. Pharmacological therapy, NSAIDs, corticosteroids, DMARDs, biologics. Non-pharmacological therapy, physical therapy, occupational therapy, splints, hydrotherapy. Surgical therapy, synovectomy, soft tissue release, joint replacement in severe cases. 16. Psychosocial interventions, 5 key approaches. 1. Counseling and psychotherapy to help cope with chronic illness. 2. School support, flexible attendance, special accommodations. 3. Family education and support groups for awareness and encouragement. 4. Peer support programs to reduce isolation and stigma. 5. Recreational therapy, sports, art, hobbies to enhance self-esteem and social integration. 17. Prevention. Primary prevention is not possible since cause is unknown. Secondary prevention, early recognition and prompt treatment, regular ophthalmological checkups to prevent vision loss, monitoring for growth and nutritional deficiencies, immunization updates, avoid live vaccines with biologics. 18. Conclusion. Juvenile idiopathic arthritis is a complex, chronic, and heterogeneous autoimmune condition affecting children. Though its exact cause remains unknown, the disease arises from immune dysregulation in genetically susceptible individuals. If left untreated, JIA can lead to severe musculoskeletal deformities, growth abnormalities, and psychosocial difficulties. However, with advancements in DMARDs and biologic therapies, combined with physiotherapy, nursing care, and psychosocial interventions, most children can achieve disease control and maintain a good quality of life. Multidisciplinary management remains the cornerstone of effective care. Thank you. Have a nice day.